So with that, can you tell us about model or models that you have in place today and how those came about? Can you describe those?
Well, for obstetric care, we have a couple of projects in the Netherlands, and I will discuss them briefly. The first one is the Santion Hospital Group. Santion is a society of 7 hospitals who are not regional competitors. That is very clever. So they operated in different parts of the Netherlands, and they have grouped, and together they have the ambition to go this way from learning from best practices. They have used for the past 3 years, because healthcare is only 3 years on their program, medical outcome data, clinical data, you name them in the value-based healthcare terms. So that's morbidity and mortality. And they have observed differences, and these hospitals were not typical hospitals who would say we are the worst because we have the worst patients, but there was a certain eagerness to learn from the neighbors. So that has resulted in improvement strategies. For example, postpartum hemorrhage, which is a very common complication in obstetrics, perhaps the most common of all, and it causes a lot of morbidity and costs. Luckily, in a civilized country, not mortality, except for some extraordinary exceptions. And that is the approach of measuring outcomes, sitting together, observing differences between healthcare providers, discussing differences in strategy, and change your strategy in your own house. So not with the involvement of patients, no patient-reported outcome and experience measures so far. They still have to do that, but clear demonstration that the approach of with a group of healthcare providers working together, comparing outcomes, discussing about improvements, implementing these, and then do the next round and observing that you're doing better. So that is a sort of proof of principle experience that it works. So that is one of the developments. The other one is the one I mentioned already earlier, that we have a little bit adapted and validated the ICHOM practice in childbirth outcome standard set for use in the Netherlands, and have used that for, in particular, shared decision making in the outpatient offices of 7 regional healthcare organizations. And unlike in the US, we do everything different in the Netherlands, as you know. So we have a risk selection based system where we allocate patients to primary, secondary, and tertiary care on basis of their risk profile, but that risk profile changes in the course of pregnancy or delivery. So then you see massive transitions from one line to the other. Now we're trying to bring that close together in a game we name integrated birth care. In every region there's a hospital with the collaborating freestanding midwifery practices around it. We also in the Netherlands have maternity care. So that is care you get once you have delivered and you're back home. You get a maternity care nurse who will stay for maximum 7 days and do typically care tasks. It also includes pediatricians involved with neonatal care, etc. So multidisciplinary, even anesthesiologists. So these regional collaborative obstetric care organizations, as we call them, a difficult word, have implemented the ICHOM set, the Dutch version of the ICHOM set, for 2 things: shared decision making, but also for learning from your own data and improving your own care practice. It was up to now, the time has been too limited to do level 3 value-based healthcare, and that is benchmarking with each other as Santion does it. But what we have seen is that this strategy has changed the behavior of the healthcare providers in the office enormously. So they tend to listen to the patient better, to understand the needs better, and make different decisions. That is what we have seen up to now. And a decision can be that we do not do treatment, we do not choose for the treatment option. That would be perhaps the most logical ones according to the guidelines. So we decide not to intervene on basis of what the patient finds important. And there is the payment system coming in, because that means that you have less revenues. We pay for interventions and not for outcomes.
Yeah, before you segue to the payments, I like where you're going. Can you clarify? So you mentioned Santion, and Santion employs its OBGYN specialists, correct?
Yeah.
And then you have independent midwives
Yeah.
region? And then what kind of payers are involved in it? All of them or certain ones?
We start to experiment with innovative ways of reimbursement only now. So that is around for 1 or 2 years. And Kees Ahaus and I are participating in an experiment in Amature, which is one of the regional collaborative obstetric care organizations in the Netherlands. And according to my observations, the most forward on this way. These are the pioneers, these people. So it will definitely also be interesting to talk to them. And there we do two things. We do a little bit of task shifting in two care paths. One of them being anesthesia in labor. Well, that is not very easily understandable for an American because in the United States, everybody has an epidural during labor, but in the Netherlands, that is not the case. So we are believing that the woman can deliver by herself if appropriately supported, and that medical interventions are to be avoided if they are not strictly necessary. We see referrals. Delivery in primary care, it lasts a little bit long and the pain becomes unbearable, and then the midwife refers to the hospital. So the patient is transported in an ambulance to the hospital from home or the birth center, and is guided and supported further by the OB specialists and the nurses, and she gets an epidural from the anesthesiologist. So that is the care chain, the care path for many. Now here we want to change that a little bit to avoid referrals because these are burdensome. The patients don't like that, of course, and it's also expensive. Now we provide the midwives with nitric oxide, laughing gas, as we call it in the party scene. We try to task shift with a different way of anesthesia to the midwives. And the second one is gestational diabetes, a pregnancy disorder that is exploding in volume because of the overweight problem. You have that in the US also. So these patients with obesity, they have impaired glucose tolerance, leading to high glucose levels in pregnancy, and that is bad for the baby because then it grows too fast and you get obesity in utero already, and that's something that influences your lifelong health. So that is an unwanted development. Up to now, these patients were also referred to secondary care. There, not only the obstetrician, but also the internal medicine specialist was involved to regulate the diabetes with diet or medication. And this also, we try to task shift to the midwives with the right protocols, etc. That is one thing, task shifting. And the second thing is to develop a method of outcome reimbursement. And that is not easy in a system that is based on monodisciplinary volume reimbursement. I see it as one of the first pilot studies, how to do this technically. How do you get the right data out of the hospital systems? What is the effect on the revenues for all the parties involved? What is the perspective of the healthcare insurer? How are the administrative burdens allocated to different stakeholders, etc.? So it's an explorative journey pilot Kees and I do with Amature to develop a model we can use and which is scalable to the rest of obstetric care in the Netherlands and ideally also to other care domains. That is where we're standing right now.
At one point, you mentioned something about analytic capabilities. Is that really essential? And how do you tackle that to ensure you can get data out to evaluate?
That is essential because if you want to calculate the costs of treatment, then that is a different story than the sale prices we use when we negotiate with the healthcare insurers, because then you really need to know what efforts and materials and staff is needed for this particular care pathway. And I can tell you that it is a challenge to extract it from the hospital information systems up to now. So what we need to do is really observing in real practice what's happening. What does the nurse do? How much time does it cost? Does it contribute to the care path or not? That is very laborious work. So the PhD students and some medical students who help her for short internships are literally observing in real practice what is happening and what is done there and who does what and how many time that costs and what materials are used, because we don't know that.
Well, so can you talk a little bit, you kind of characterized the system that you built. It's a bundled payment, is it not?
Yeah, that is also some of a story because 2 ministers for health ago, he was very in favor of value-based healthcare. He said, well, we're not going to redo things that have been developed elsewhere in the world. So we go to Boston to Blue Cross Blue Shields and to Arnhem, and we learn how they do the costing and how they have developed and used outcomes. But that was not very welcomed in practice, and also not by the civilians, by the patient representatives. So she was determined to make that the regular way of costing in a couple of years. We're 6 years further than her last term now. And even now, it's a facultative option. You can do a bundle payment that deal with the healthcare insurance companies, but it's not compulsory. So up to now, from a small 80 of that regional obstetric care collaborations we have in the Netherlands, it's around 78 or so. Only 8 have gone that way up to now, and Anature is one of them. It is also needed that it will be an element of reimbursement, that you not only pay for the clinical or patient-reported results, but also for the process of improving and learning this way. We have quite nice discussions with CZ at Artis.